what I'd like to do is to follow on previous speakers' topics and give you a roadmap of what is happening in Hong Kong. And to a certain extent, I do this from my personal experience in the past 30 years of looking after patients, working in the area of care for older people. And I'll finish up with what I think, how we should go forward in the area of medical education on this topic. So this is the roadmap. The three major areas I think are very challenging. The sort of immediate, very near end-of-life situation, euthanasia, and we haven't really started to talk about physician-assisted suicide when I think this probably occurs in an informal way. Advanced directives, quality of dying, that's one big area. And then the second big area is to do with long-term care, because when you're near the end of life, in the end of life, you need a lot of care. And it throws up issues of autonomy and dignity and elder abuse. And finally, equitable service. How do we view this sector of population? They're not productive, they're not attractive. Do they have lower priority? And what I'm going to do is just to flag up what's happening, and I think this would be a lot of material for further discussion in the workshops later on. So this is a common discussion. Is euthanasia an ultimate act of autonomy? This is my own life. I don't want to suffer. Who are you to stop me from taking my own life? Or is it, the other side is a reflection of poor care? Because if you have great quality palliative care, nobody needs to suffer. So why should we talk about euthanasia? Now, it's legalized in some countries, but there's huge variations, even within Europe, from west to east. But what about in Hong Kong? Many years ago, there was a public survey carried out by Alice Chong in City U, where she found that about 60% of people want to talk about it. So among the lay public, they're interested in this issue, but then it was considered a very sensitive issue, and nothing happened after that survey. But it is true that the quality of end-of-life care in Hong Kong could be improved on. See, typically the deaths are slow, as associated with chronic diseases in persons with multiple problems, marked by increasing dependency and care needs. The quality of life during the dying process is often poor because of inadequate treatment of distress, fragmented care, strains on the family, and support systems. I think that if you have experienced relatives or friends who are dying in hospital, you know what I mean. And certainly people who provide day-to-day care in the wards, where there are many, many elderly people, you would have witnessed something. And then finally, of course, it's difficult decisions about use of life-prolonging treatments. A lot of controversies, a lot of arguments between relatives and doctors. And here are a list of barriers towards improvement. I mentioned before it's a taboo subject. People don't like to talk about it. To a certain extent, it represents medical failure. With new technology, why should anybody die? The public's perception is that, why don't you invent something, keep people alive forever? There's no understanding of the concept of futility. Lack of trained people, lack of research, lack of psychological support, and to be honest, within the healthcare system, it's not high priority. I'll show you some evidence later on. Now, advanced directives, the Hospital Authority has taken a lead, following on the Law Reform Commission many years ago, where they suggested that there should be a law like United States. Subsequently, the Hospital Authority, after many years, designed an advanced directive form. It's in the computer, it's not widely known, the public certainly don't know much about it, and it's certainly not enshrined in law. But what about the public? This survey carried out in people who live in nursing homes showed that 88% prefer to implement advanced directives. They certainly prefer to be informed of terminal disease diagnosis. So there shouldn't be any hesitation in discussing these things. 35% prefer to receive end-of-life care and die in their nursing home, and there are legal issues preventing them from doing so. After this was done, lots of initiatives were carried out, but we still haven't moved forward at all. Now, the next area is to do with long-term care. So these are the major things we come across day to day. The tube feeding. Practically everybody is on tube feeding, unlike other countries. Apart from tube feeding, then this issue of PEG, percutaneous gastrostomy. The use of restraint, toileting needs, because people need help to go to the toilet, you don't have time, you give them a nappy when they come to your ward. Elder abuse, of course, we see it in the media. So these are issues relating to not just hospitals, but residential care homes for the elderly, problems with autonomy, dignity. This is a thing, some facts about Hong Kong. Although it's 2004, it's 10 years ago, I'm afraid we've just begun to make a dent in this situation. And this shows that Hong Kong has very, very high prevalence. It's number 2, really, of using restraint in nursing care homes, and you can translate that into hospitals as well. Now, the final area I want to touch on is equity in care. We can talk about accessibility to primary care. There are variations. Hong Kong is very small, 1,000-something square kilometer. Even within such a small place, there are variations. You might not believe it, but it's true. What about healthcare resource allocation? Is there ageism? Are the elderly ranked lower? Because we're all in, if you think that we're all in a lifeboat, there's limited space. Should we chuck out people who are not productive to society and doesn't look good? And then health outcomes. There are certain health outcomes which is an indicator of quality of care. There are regional variations, again, even within such a small place, such as Hong Kong. And then the question is why? Why is it important to talk about equity? Those with equal needs should receive equal care, I think is a universally accepted point. The phenomenon of ageism, do they receive lower priority than younger patients with regard to expensive health technology? How do we arrive at that decision? And then the other thing is older people cost more in healthcare. So how should we allocate, distribute the resources? Obviously, we need to avoid care plans based on age alone. There should be better ways of telling us, guiding us what to do. And currently, there are no formal systems to guide us. Then the issue of money, you can't talk about it in abstract without talking about money. It's affordability. So this issue has really not been addressed systematically or consciously, right? And so it gives rise to wide variation in quality of care at any given level of resources. This is one scenario. Somebody who's in the minority, can't speak Chinese, totally demented, walking around with a knife. Normally, we would put this person in an old age home, but there are very few homes for the non-Cantonese speakers, non-Chinese speakers. What would you do here? This is a common scenario which some of you may recognize if you're in middle management. How do you balance? How do you decide what to do using the common ethical principles? We're at great pressure to discharge patients from acute hospitals. And there are yardsticks, if you're more than 4 days, something's wrong with you. So what are you going to do? When a lot of people, you don't even know what's the matter with them after 4 days, right? And then this is related to your personal gain. It's your performance measure, whether you keep to this. So how should we deal with these situations? So we can discuss that later on. But coming back to variations, this study done some time ago, where if you look at health outcomes, not just in terms of mortality, but in terms of frailty, quality of life, these things are more important to older people as they get older. They don't mind dying, but it's the quality of life and whether you're independent. And of course, we know that lifestyle and socioeconomic status can affect these things. But one interesting thing we found that which region you live in is an independent contributor. So which region you live in obviously affect your lifestyle and socioeconomic status, but there's a direct pathway, and you'll be glad to know, people who live in Shatin, that Shatin seems to be pretty good, one of the best, okay? So this is path analysis, and here we use frailty index as an outcome, and basically these are all interrelated. This is dietary quality, alcohol use, smoking, physical activity, and they all link up, but there's a direct pathway from district to outcome. So we need to know what's happening there. So this is just a summary of that bit of finding. Now, if you look at hip fracture case fatality, so a lot of hip fracture occur in elderly people, and the mortality is quite high. And case fatality, to a certain extent, is a reflection of how frail you are, but also what the healthcare system is it efficient? Is it effective in dealing with this? And you can see there are lots of temporal and spatial variation in case fatality. This is earlier data, and this is later data. So at 30-day, 180, 360. In general, red is bad, yellow is good. So you might recognize some similarities, Hong Kong Island and the New Territories West. What is it related to? And this is incidence, because this is relating to prevention and general health and so on. But the positive thing is it used to be pretty bad. Everything is red, 2000, 2004, but 10 years later, less red. So something is happening. And it's important to kind of understand these variations. This is stroke case fatality. The top panels are the earlier ones. And so this is quite encouraging. Things are improving, but still regional variations, and similarly with case fatality. Now I want to address this issue of bed adequacy. There's a lot of controversy about this. I chose a ratio of the number of total days in hospital divided by the number of admissions. This is from a user's perspective, because we have this revolving door phenomenon, right? So the idea is if this ratio is this ratio would kind of reflect whether you have enough beds. If you have enough beds, maybe you won't get discharged so early, so then you won't get remitted too early. So you can, it's just an indicator, and you can see that pretty bad situation in Northwest. What about primary care adequacy? Now we know that primary care is, you have to, by and large, pay to see the doctor, but the really poor people, they have primary care because accident and emergencies open 24 hours a day. And everybody knows where hospitals are. So one ratio you can use is the number of times you visit A&E divided by the number of times you're admitted. So if you're using A&E a lot as primary care, then the ratio would be high. And so you can see, again, there's huge variation. The green is the best, and Northwest is not so good. So these are some of the facts that we can document that lead us to further exploration of the whole issue of equity in healthcare. Then I want to talk about prioritization. That money is limited, but how do we decide whom to treat? How do we decide how to spend the money? There's been no official sort of conscious debate about this. This is a survey of the general public, which include professionals. is that of 12 health services listed here, how do you rank them? And you can see that the top rank is treatment for children, right? Second is high-tech stuff. And what about people 75? It's pretty low down. So together with special care and pain relief for people who are dying, long stay hospital and so on. Now, how does that compare with other societies? Okay, so other things we collected are who should decide. Now, 44% says that priority should be given to the young. So it's not even half, right? Should we collect public opinion about this? A lot of people agreed. And who should set priorities? Doctors, public. Politicians, quite low down. The responsibility for rationing healthcare should rest with doctors. A lot of people think that doctors should be involved. So it's interesting that what about in the UK? Similar things about in general. But how do they rank these 12 services? Treatment for children, yes, exactly the same, right? But then if you look at, treatment for people aged 75 and over, pretty low down. Similarly with long-stay hospital care. So are we seeing a pattern that there is ageism, it's subconscious, we don't talk about it, but are we subscribing to that lifeboat scenario? One thing I want to point out, which is quite dramatic, is this high-tech surgery. I mean, what's the matter with Hong Kong? Is it a media thing? You just report on the latest advances? It's only 7 in the UK. Maybe the UK media has more balanced view, right? What about care for pain and relief for people who are dying? Quite low down, but in the UK, it's quite high up. So it gives us lots of room, thought. Now, if you're interested in delving into this, I kind of documented this in this volume, so you can check it out. Then I want to go on to the next part of the talk, is how should medical education address these challenges? Because we have this workshop, we talk about it first. We need the facts, like Richard Yun said. We need to know what the facts are first, and previous speakers. We need to train the teachers and service providers. So the curriculum should be a core part of training of all the health and social care professionals, and it should be anchored in real-life cases. So it's very relevant, the Singapore experience, real-life cases discussion. And finally, I think even more important is no use talking about it. When you actually work in the service setting, we got to continue with these activities, this way of thinking, and incorporating them as continuous quality improvement initiatives in hospitals and wherever you work. Is this too idealistic? Personally, I think that this is the only way in which you can make bioethics discussion relevant to healthcare in a continuing way. Let me give you some examples. We talk about end-of-life care, how we deal with people who are dying. I won't talk about cancer patients because for many years there's been palliative service targeted towards people with cancer. So I'm talking about people who have non-cancer condition, chronic neurodegenerative diseases, renal failure, COPD, etc. Now, CQIs, everybody is familiar with this plan, do, check, act cycle. Quite a few years ago, we decided in Shatin Hospital that we will embark on that because we've seen a lot of things. A group of people, senior doctors, thought that we should make a difference because we know what we should do and we're not doing it. And the first step was to gather data to identify areas of improvement, which is documented in the descriptive part. Then we formulate a plan to implement. And here we encounter major difficulties. Our plan seems simple, that we just diffuse these things by ward. We have many wards. Each ward has a nurse in charge and a ward improvement team. So we can diffuse it down there. But the very first meeting we had with senior people, the feedback, I don't know how to do this. I'm not trained to do this. I'm not religious. I don't have any religious belief. And so we had to say, well, actually, you're dealing with this issue day after day after day. We're just talking about improving the quality of care. And there was a major cultural barrier. And then when they spread it down to the ward improvement, we encountered a lot of problems. So eventually we had to decide on role play to finally get the thing going. And then we have to evaluate it. What does it do and how to disseminate it? And so this middle article documents this very painful process. Actually, the journal is out of print now. But the outcome was documented in Journal American Directors Association. Documenting outcome is vitally important because it gives you statistics that health care providers, the policymakers would take notice, right? To include costs and so on, cost benefit. Now, what about restraint? I said earlier on that Hong Kong has the highest prevalence of restraint, and these are the common reasons for why restraint are applied. I think you're all very familiar with that. So again, we thought that this was not right, because actually, if you go to Australia, UK, I mean, nobody's using restraint. So what's the matter with Hong Kong? And from all levels, right from the top, it's the thing to do. It's actually considered quality to restrain people, because then they won't fall. I mean, there's a lot of misconceptions there. So again, a group of people who are enthusiastic, who feel that they're doing something that is not right, got together. And we were fortunate because the GM nursing happened to be doing a PhD for PolyU, and this was the topic, restraint reduction. So you can see it's very important to do things in an opportunistic way. And so we were able to implement all this step, and we got around the issue of management objecting. It helps to be a professor of medicine to talk to people. And so basically, it was a bottom-up thing where the staff understood the importance, and then they designed various ways of dealing with it. This bottom-up approach is vital because they see the effect, and then they're very encouraged by it. This is use of sensors, and then use of low beds. So if you fall is less distance to fall, less opportunity to damage yourself. The use of hip protectors, locally modified, which would prove to be effective in randomized controlled trial. 33 people wear it to protect one hip fracture. And then they design these things where basically you're sleeping on the floor and you're surrounded by these cushions. And the nurses had a great time with that. So it's like there's this, you need to get this kind of initiative, this sense of doing something to counteract the day-to-day frustrations of doing something that's not meaningful. And you can see it provides some result that you reduce restraint, you do not increase falls rate. That's the first step to show, because otherwise nobody will believe you. And then you prove that actually, if you don't use restraint, the length of stay is reduced. That's very important to drive further improvement. And so with retrospective record, we were able to demonstrate these statistics. Now, with these statistics, you can then continue to disseminate this practice. Quite important, average length of stay reduction for confused patients and so on, dramatic reduction. So anyway, I just want to conclude by saying that in Hong Kong currently, there are many practical examples relating to ethical issues among older populations that we as service providers come across every day. And there seem to be still a lack of awareness or disregard about these principles. So certainly I subscribe to the fact that bioethics education should be a core component in the training of undergraduate health and social care professionals, because it's not just the healthcare, it's the social workers as well. Certainly for managers, policymakers, and most important of all, it should be applied to practice, because otherwise what you've learned kind of dissipate in your many years of professional life. And I think if you complete this loop, then we're on track to improving the situation. Thank you.